Hi there, my name's Damien Rowland. I'm a doctor, but I'm also a dad. I have two daughters, Isla, 13, Bella, who's now 10, and both of them have been to hospital. Isla's broken her arm, she's had some elective surgical procedures, and Bella, when she was 6 or 7 weeks old, had query meningitis, and we spent a very worrying 48, 72 hours in hospital. So I've seen children's emergency care from both sides, both as a worried parent, but also as a clinician who's trying to do their best to make ill children better. This is a painting. It's from Luc Fildes, and I think it really encapsulates how medicine can appear. It's a bit stereotypical. I get that. We have the thoughtful white male doctor with a beard looking quizzically at a child in the middle of the picture. But what's clever about this painting is if you look to the back on the right-hand side, there are worried parents. That there's a father with his hand on the shoulder of a clearly distraught mother. And this is a picture that probably needs to move on a century, having the parents part of the process, clearly not having the sage white man making all the decisions. But I like this painting because it reminds me of that triumvirate, that everything that I do in pediatric practice is clearly about the child or young person, but is also about the parents and carers. And that I am just a third of that picture when it comes to decision making. And there are some things in pediatric practice which are really obvious. And I think nearly all parents and carers can recognize the critically ill child. And this talk is not about the critically ill child. I'm not talking about the child who's not breathing, who is unresponsive. This talk is about the children who may have serious disease, but it's not always apparent at the start of their illness. And I want to demonstrate a point. Here we have a lot of snowmen, but what I want you to do is find the panda. Now, the panda is there, I can assure you. And I use this picture a lot. I use it with medical students. I use it with school children. I go out and teach in schools to give an introduction to medicine and decision making. And I use this with really experienced doctors. Now, some of you may have found the panda already, so I'll put you out of your misery. The panda is there. Why I use this is because once you can see the panda, it's really difficult to unsee the panda. So if I show this again, you'll know exactly where the panda is. But there was a period of time where in all of this picture, you couldn't see the panda. And it's really important to hold on to that retrospective instinct that we have is once something's obvious, it's obvious. Let me give you a more medical example. This is a computerized tomography scan. So it's lots of x-rays put together, and it's of the lungs. Now, some of you will have always noticed that there's an obvious abnormality in this CT scan, even if you're not a medical practitioner. It's there. There's a gorilla in this CT scan. Now, I suspect most of this audience will have noticed that gorilla pretty quickly. But in a study of lots of radiologists, those doctors who look at CT scans all the time, 20 to 30% of them, when shown this particular CT scan, didn't see the gorilla. And why is that? Are they bad doctors? Do they not know what they're doing? Well, no, it's because there's a lot of pattern recognition in medicine, and their eyes are focused in on the things that they're used to seeing. And this thing that came out the blue, they just didn't see at all. And so taking the previous one I've shown you, that sometimes things can be there in front of you, but you just not see them, or you can be trained just not to see things that aren't expected. I hope you start to see now that if you are seeing hundreds, if not thousands of children, those children with those minor abnormalities might not stand out in the way that you think they would do. Now, they may be obvious to the parent, but for the doctor or nurse who's been working a very long shift, seeing lots of patients, that might not be apparent. And to put this into context, there are 4.3 million children who present to emergency departments and urgent care centres throughout England every year. There are 156 deaths from infection. And I do not want to trivialize the tragedy that occurs when a child dies of an infection. But in the context of all the children seen, this is a really rare occurrence. And you may well have heard the term sepsis. And sepsis is a challenging disease, and it's something that we must get much better at treating. But you may hear reports of sepsis being common, sepsis being everywhere. Why are we missing sepsis? And one of the reasons we're missing it is it's not because it's common. It is because it is so rare and it's so difficult to spot. And it is like this proverbial needle in the haystack. And so how can the public and parents and carers be part of a puzzle to help clinicians and systems make sure that the right children are getting the right care and the right treatment at the right time? So I want to talk about a few common illnesses that children present with, and let's deconstruct some of the challenges around that, and see if I can bust a few myths, both for parents and carers and perhaps for professionals. So let's take fever as a prototype condition. For fever is a very common concern for parents and carers. But I need to be clear, fever is not a disease. So a disease is caused by a virus or a bacteria or immune condition or breaking your bone. It's a physical thing. Fever is the body's response to something. And that response is a good thing. What fever does, what the brain is trying to do, is change the body's temperature to make it more difficult for viruses and bacteria to replicate because they don't like high temperature. So fever is a good thing. The challenge with fever is it makes you feel rubbish. Everyone's had a fever, and you know what it's like when you feel that shiveriness, and clearly children get very distressed. But fever itself is something that we need to happen. It's an evolutionary process. And fever itself will not do you any harm. Now, yes, there is a small percentage of children who get something called a febrile convulsion. They have a seizure when they have a fever. But again, those are almost always self-limiting. And while, yes, I get they're very frightening, but that won't do the child any harm. Lots of children do get them. There tends to be a family history. So it's not a bad thing. And so we need to remind ourselves that fever is not bad. Why do we think fever is bad? Well, there's lots of reasons, but one of them is because of this chap, Claude Bernard. What he did is he took some lizards and he heated lizards to different temperatures, and he found that the hotter that you made a lizard, the more likely that you were to die. And he created this hypothesis that high fevers, increasing your body temperature, was a bad thing. And from then we've had this concept of fever phobia. And what's interesting is if you ask parents about how high temperatures could go if we didn't do anything about it, the answer for a lot of people is beyond 41 degrees, and the body can't do that. It is possible to make the body more than 41 degrees, but that's only if you're trapped in a greenhouse or a car. The body itself puts maybe your temperature normally up to 38, 39 degrees. Yes, it sometimes does go above 40, but that's relatively unusual. And so there's often a panic about how high the fever may go, but the body's quite good at self-limiting what happens. And as I said before, there's lots of concern about what happens when you have a fever. And if you see that concerns, up to 50% of parents may believe that fever causes brain damage, can cause coma, can cause blindness. And these things just don't happen. And as a population, we need to understand that a child having a fever is your normal body's response to an infection. Yes, you should treat the distress. I wouldn't want, if I was feeling cold and shivery, I'd take some paracetamol and ibuprofen. So when a child is distressed, they can also have some paracetamol and ibuprofen. But you're doing that to treat the distress. You're not doing it to treat the fever. Now, one of the challenges that we have is that there are a body of children who, when they do have a fever, have a more serious infection. So how do we know when someone has more than a fever? Well, we're looking for those things in behavior, and we often look for various physiological features. I think you may have heard those as vital signs: your heart rate, your respiratory rate, the color of your skin, your oxygen saturations. Now, for the child at home who's kind of playing around, maybe get a bit sleepy, feels a bit miserable, they get a fever, you give them some paracetamol because they're distressed, and they perk up, and you may notice they've got a bit of a cough, or they have a diarrhea or some vomits, but you're not too else worried about them. That nothing probably needs to be done. That illness will resolve over a couple of days. Sometimes, however, that your child may change color. They may be very blue around the edges. They may have very labored breathing. So they're breathing perhaps twice as fast as they normally are, and they go a kind of a dusky color around their lips. That becomes a cause for concern, and you may take that child to see a healthcare practitioner urgently to get them checked out. Now, if we look at children presenting to an emergency department, we use those vital signs. We use deviation from normal for heart rate and respiratory rate, etc. And what we find is, if let's take 100 children, 40 children who present to the emergency department with a fever may have very abnormal vital signs. So a very high heart rate, a very high breathing rate, things that are outside normal values. The challenge for us is, of those children with abnormal vital signs, only 0.4% of them will have a sepsis condition, a condition where that infection becomes overwhelming and needs urgent treatment with antibiotics and support. And so you can see that this challenge is that lots of children even come to an emergency department with some abnormality, but very few of them actually have a disease that needs treating. This big block of red you see on the left-hand side is mainly due to viral illness. And the number needed to treat, so this is a medical term, but what it means is we need to treat 256 children with abnormal observations to prevent one child getting a missed infection. And so that's a lot of children who you need to jump in and treat unnecessarily to have an effect. And this is why, and I can see the frustration and feel that frustration in parents and carers, is that you come to the emergency department, that you're worried about their child, they may have been breathing a bit faster, they may look a bit unwell to you, but the majority of those children, even like that, when they come to the emergency department, will not have a serious disease. And so that becomes really problematic. Is how do we find then that tiny proportion of children who have serious illness? Well, there's a few things that we can do. So we can stratify some risk. We know, and this is a real take-home message for everyone, that if your temperature is above 38 degrees and you're less than 3 months old, that is a big red flag. And if your child has that, you need to seek medical help immediately, because your risk of a serious illness in that age group is much higher than normal. It can be up to 10%. We know that children between the age of 3 and 6 months, especially if their temperature is above 39 degrees, that becomes a slight risk factor. And for any child who's had a temperature for more than 5 days, again, that needs some form of medical review. I do need to be clear, though, that is a temperature that you have a couple of times a day, 4 or 5 days continuously, not a bit of a temperature at weekend, then you get better, and then you get a temperature again 5 days later. Unfortunately, the amount of viruses out there, especially in nurseries and schools, means that these things can happen. You can have 2 colds in a week. So we're talking about 5 consecutive days of fever. And those are big things that you should hold on to. Now, we've had a recent challenge in November time and early December. It became realized that rates of streptococcal infection, you'll have heard the terms perhaps invasive group A strep and scarlet fever, reached much higher levels than they normally would do. And that was a real challenge for both parents and carers and the public. There was a lot of alarm because we had a number of deaths from this very nasty disease, invasive group A strep. It really is something that can overwhelm the body quite quickly. And despite what you may have heard on the media, it is very difficult to pick up, and we're not even certain that even early antibiotic administration sometimes will prevent a death in this particular condition. But this left a real challenge, is that the public are aware, and doctors are aware, that we have higher circulating levels of this particular condition. We know that some children may be overwhelmed by this infection. It is important to note that 20 to 30% of the whole population carry this infection just in their throat normally. And we're still trying to do researches. Why is it that some children and adults just carry this infection and are never harmed by it, and there's another proportion, a much smaller proportion of children who can become really unwell? We still don't really understand that. But what we had to do was at least alert the public. And I think when that message went out, it caused a lot of alarm. We had huge numbers of people presenting to GP practices and emergency departments. And that causes a problem in itself, because these systems become overwhelmed. It was very difficult in our emergency department to keep on top of the patients that were arriving. There were really long waits to be seen, and that becomes a risk in itself. And so we started to try and double down on some of the advice that we were giving, to be quite clear about the symptoms or the red flag features of illness. But ultimately, I think we reached a point where there was a decision made that we would change some of our criteria for giving antibiotics for some of these simple throat infections, tonsillitis, and that drove even further demand. And as you may have been aware, that we did have some supply issues for antibiotics. And as you can see, the story I'm presenting here is that lots of things have consequence, and that once a narrative plays out and there's concern, that increases demand. That demand overwhelms services, changes the way that people do things, sometimes further increasing demand. So these are not easy things to look at, and we all, as a medical profession, really struggled over the last couple of months to cope with that. Now, it does look like that those numbers have come down. We're trying to return to our normal practices, but this hasn't been an easy period, and sadly there has been tragedy throughout the country in children who just have succumbed to this really quite dreadful disease. Now, breathing difficulty. So again, one of the real common reasons for presenting to emergency departments and your GP. And I want to tell you about a study. This study was a nationwide study, but we undertook it in Leicester. And what we did was, children presenting with potential pneumonia were given a low or high dose of antibiotics for a short or long duration. So you either got a low or high dose for 3 days, or a lower high dose for 7 days. So there were 4 potential treatment arms that you can have. And what we found is it really made no difference whether you had a lower high dose of antibiotics or you had it for a short or long period of time. And this is a graph of cough resolution after having a potential pneumonia. And what I want to draw your attention to is that about 75% of patients had a resolved cough, but only after 3 weeks. That means 25% of children who presented in this study that recruited 800 patients, so there's a lot of patients, kind of a valid number to draw wider conclusions from, is 25% of children, after having a pneumonia, still had a cough 3 weeks later on. And it's important to note that. I don't think we're clear enough sometimes in the medical profession about the longer term side effects of some of these illnesses. And this didn't matter whether you're on the low or the high dose of the antibiotic. And the same thing applied whether you're on the short or long course of the antibiotic. And this made us really wonder about, okay, what are we using antibiotics for? And it's very likely that a lot of these children, even with a bacterial pneumonia, a pneumonia that traditionally we thought would respond to antibiotics, because there wasn't that much difference, it probably means a lot of these children will just get better anyway. They may have a bit of a cough, but they will eventually get better. And there is, in fact, a study undergoing in America where we are looking at giving antibiotics to a group of children and giving no antibiotics to another group, a randomized controlled trial. And we may find that actually we don't need antibiotics as much as we think we do. This is going to be challenging, and I think a lot of people will struggle with the concept of that. But it's important to note there's lots of things that we do in medicine that are probably a bit of over-treatment. And what I think the future holds is not whether we look at a child and decide on their clinical symptoms. What we might be looking at in the future is on their genomics. So it's likely that a child's response to an infection, whether they become seriously ill or not, and whether they need treatment, will be based on their genes and whether they have the ability to fight infection or not. And I think watch this space over the next 10, 15, 20 years or so. Diarrhea and vomiting, massively common and quite distressing for families, especially with the younger infants. Very messy, obviously. Causes lots of concern about dehydration. And one of the things that is crystal clear to me is that we really need to work much harder from a public health perspective at empowering parents to make, empowering parents to have the education they need to make decisions that are pragmatic. And if I was Prime Minister, I'd add in healthcare into the national curriculum. It's not about, I don't think, doing maths to the age of 18, but I would like everyone to have some first aid training and some management of simple diseases. Because diarrhea and vomiting is a good example of something where just a bit of diarrhea, a couple of vomits is not going to do you any harm, and your child's very likely to get well. And the key thing is that we get really, and we're good at doing this in Britain, is a bit obsessed about bowel habit. One of the things that parents do when they change a nappy is you weigh that nappy. It's a reflex action. But that's a really good thing to do because it tells you how much urine that child's passed. And urine output's a really good measure of how hydrated your child is. And as long as they're having regular wet nappies and they at least have a wet nappy every 12 hours, it's regardless of what you see them taking in, it's likely that their kidneys are perfused enough and they're not going to come to any harm. And we have parents come to us who are really concerned about the fact that their child can't possibly be hydrated because they've had so many vomits or they've had so much diarrhea. But if you're still passing urine, what little you do take definitely goes in, and it's important to remember that. I do a test. If you take a nappy and you roll it up and you chuck it across the room, if it hits the wall with a thud, that's a good nappy. There's a lot of urine. If it kind of flies around a bit, that probably hasn't got any urine in, and that's a good measure of what your child is producing. The flip side of that is these some of the families get really concerned that they've not seen any urine output at all, but their child appears well. And again, having just talked about the importance of urine output, there's this balance is that if your child is kind of still eating and drinking, seems to be walking around, is happy playing on a game, but you've not seen them urinate in 24 hours, it's highly unlikely that they haven't passed urine. It's that you've probably missed it. And so we have to have this pragmatic balance between what we think is a symptom and what is a sign. And this is what I get worried about when if a family member comes to me and says, look, they've been vomiting, they've had diarrhea, they've had fever, but they're just not right. Now that's the red flag to me. That's very different from the family member who comes to me and says, look, I'm really worried about my child's fever. And you look at the child and they're fine. And you ask the parent, has your child been more unwell recently? No, but it's the fever. Can you do something about the fever? Can you do something about the diarrhea? Can you do something about the vomiting? And what we need to do is start angling our lens about what are the behavioral characteristics of this child that you're worried about, rather than being fixated by a particular symptom. And this becomes really challenging, though, when we think about abdominal pain, because this is a difficult symptom to deal with. It's very distressing to see a child in a lot of abdominal pain. And there is all sorts of potential causes, and some of those are quite serious causes. Parents may be thinking about appendicitis, maybe thinking about twisted bowel or blockages. But the majority of abdominal pain is self-resolving. Now, one of the key things here is that the concept of distractibility, how long is your child in abdominal pain for, but also the way they're holding their body. And one of the big things that you learn over time in emergency medicine is that children who become very distressed and are very outwardly distressed about their abdominal pain are the least likely children to have severe disease. Now, that's not an absolute, there will be some exceptions, but I'm much more worried about the pale child who comes into my department, who is lying completely straight, who doesn't want to be moved, who isn't making a sound. And that is much more likely to be a severe disease than the child who's rolling around on the bed telling you how much pain they're in. And that's because that second child, the one who's rolling around, is much more likely to be a crampy abdominal pain. And I'm not dismissing that child's perception of the pain, but crampy, colicky abdominal pain, yes, it is distressing, but it rarely has a serious cause. And what that needs is good distraction, some simple analgesias, a hot water bottle, a bit of tummy rubs. They're all things that help those type of children. The other thing that causes colicky pain is constipation. And one of the things I've never really quite understood is that parents and carers don't seem to think that constipation is severe and never like being told that that's a diagnosis. It seems to me that appendicitis seems to be quite a cool disease to have. Oh, I want some blood tests, doctor, because my child might have appendicitis. And when you tell them, well, I think it's more like they've got constipation, they're almost offended that you've mentioned this diagnosis. And I don't know why that is. Is it a British sensibility? Or is it something that you just don't like admitting to other family members or friends? But constipation is extraordinarily common. And one of the issues is having said that we're really good with young babies about looking at nappy habit, as children go through the stages of toilet training, we stop looking at their poo. And children stop telling us that it's painful when they have a poo. And they stop knowing what their normal is. And this funny thing is their poo normal? Oh, yes, of course it is, doctor. It's always been normal. Well, what is normal for you? Because little round balls that are stuck together, that's not normal. That is a constipated stool. And poo is, even if it's sausage shaped, might not be normal for that child if they have a different consistency normally. And so I spend a lot of time drilling down into the actual stool formation. Yeah, it can be a bit of a fun conversation to have with kids sometimes, and sometimes it can be a difficult conversation to have. But one of the commonest causes of crampy, colicky abdominal pain is constipation. And please don't dismiss that. It can be quite a difficult diagnosis to reach sometimes, and it can take a lot of treatment. So it's not something to be admonished or embarrassed about. As I said, for the child who is vomiting with abdominal pain, that is something that is important. The thing to think about is the change of color of the vomit, and people get a bit confused about what bile is. Bile is a dark green avocado color. That fluoro yellowy greeny color is not bile, and that is normal stomach contents. If you see a dark browny greeny color, that is bile, and that shouldn't be seen in vomit, and that is something that needs review. And then we come to head injury. This is, again, really common. Just the point I want to take here is that the child who has a head injury but returns to normal, but is maybe a bit sleepy, is allowed to sleep. You might want to check on them that you can rouse them, but there's sometimes this fear that we can't let children sleep. So we keep them up. They then become really irritable, and then it becomes difficult to know whether they have had a serious head injury or not. So it's a bit of a myth that kids can't sleep. The reason this has emerged is because you're changing GCS, or that your level of alertness is something that we monitor in hospital. And if that's decreasing, then that is a worry. But that's not the same as being asleep. And if your child has a little sleep afterwards, wakes up, then that's okay. That's not an issue. The other thing about head injuries is being knocked out. And I think if you are concerned that your child has had loss of consciousness, that is important to get reviewed. But again, actually, in our guidance, you can be knocked out for up to 5 minutes. And if you recover from that, you don't need a CT scan. And in fact, you are very likely to have no longer term consequences whatsoever. So there's a talk through the range of normal kind of conditions we have. There are some special cases, little babies. Babies less than 6 weeks old are much higher risk. There are children with chronic conditions, and I've not even touched on mental health problems, and I don't think it's within the remit of the talk to cover that. But I wanted to acknowledge that these things do exist, and they do impact on the presentations that we see in emergency department and GP practices. What I wanted to move on now to is some of these decision-making processes that we use in medicine and how they can sometimes go awry. So this is Guess Who. Guess Who is a game where you have to guess your opponent's person. You ask them about their hair color, their eye color, whether they've got a beard or not. And I was trying to teach my 6-year-old daughter, Isla at the time, how to play this game. We spent about 20 minutes talking about it. I found it a bit difficult to explain, but we got there in the end. And Isla then, I said, Isla, you go first. You ask the first question. And she went, is it Anne? And I looked at my card and I went, yes. And she went, yay. And we've never played Guess Who since. And that's because she believes that why it's not a game worth playing. I can just guess the name and it all comes right to me. This is a really easy game. Why play it again? And this is a common phenomenon where you gain a bit of experience, you see something happening, and then you believe that you are more confident than you should be. It's called the Dunning-Kruger curve, or what I really like is arrogance in the face of competence. And this happens a lot in medicine, sadly, but it happens in all walks of life where you get a bit of experience with something, you think you're very good at it, and then something happens which you realize, oh my God, I've got so much more to learn. So your confidence drops, and then it takes a bit of experience to pick you up. And one of the things that we see happens is those families who have a child with a viral illness but receive antibiotics. Viral illnesses last normally 3 to 5 days. Often the frustration with an illness peaks at around 3 to 4 days. You visit your general practitioner, they may give you some antibiotics, you may go to the emergency department, they may give you some antibiotics, and then your child gets better the next day. And that correlation is so clear that I went somewhere, I got something, they got better. And that's a one-off point in that child's lives. But you then think, well, that's my experience. So why should I not seek antibiotics or tell people about that for the next time it happens? But actually, that's your lens on a very minuscule part of a bigger population. And this is where we run into difficulties, because that experience in terms of what you've experienced as a family for your patient versus a much broader experience of what normally happens if you don't do anything is really difficult. And then especially if you're a family who experienced harm, perhaps you didn't get antibiotics when you should do, or your child did become critically unwell, then that really does bias what happens. And so we have a real problem. And then we have a secondary problem in the way that we present that information to families. So you've heard me talk about red flags. Red flags are really important. There are these features of illness that we can use to tell people and help people recognize when they need to seek medical help. But we often put the red flags first. And what I think we need to do is shift that paradigm around so that the green flags are first. These are the things that should reassure you, the things that you can stay at home for, and then work up to the things that you do need to seek help urgently for. And it's an important frame because it stops that scaremongering. It stops you thinking, oh my God, could my child be ill even if they don't have any features of illness? And then we have another problem of this traffic light system being a bit different for families and a bit different for clinicians. So we have guideline risks that say, if you're red and you've got these symptoms or signs, then you need this specialist input. But the family will go, well, my child needs help immediately. We can have green characteristics that say you don't need any treatment, you can go home. But that family is saying, my child's still got symptoms. How do you help me do about that? And if we don't bridge that communication issue, this is where we run into difficulties, because most of the time the child probably will be well. And even if we don't do anything, they're going to get better anyway. But there will be some times when that safety net advice isn't good enough because of this communication problem. We've not addressed the parent or carer concern. And so we send that family away, and that family feel admonished. They don't feel listened to. They've not been given practical advice about what to do and how to help their child. And so if their child might be getting worse, they don't seek help when they should do. And so we've got a lot more work to do, I think, on bridging that communication imbalance. So what can you do? Well, sadly, one of the things is that you may have heard about 111, and 111, while it gets a bad name sometimes because it's a bit overloaded, it is a very powerful system, and it is a relatively safe system for getting advice. One of the difficulties they have is if you go to 111 online, you can't use that for under fives. You have to make a phone call. And that is something that we probably need to address. But there's lots of local guidance. So we have a self-care at home for children aged 0 to 9. If you use the QR code, you can get straight to the link, or you can go onto the Leicester Hospital's website or just Google it. And that's a guide that contains lots of pragmatic advice and contains some of the pointers that I've already mentioned earlier in this talk. There is also a healthy teens from early years to teenagehood that you can look at. There's healthy for under fives.co.uk, and there's health for teens.co.uk. And again, lots of pragmatic advice, self-help, first aid care, etc., etc. There's also a really good national website, started in Southampton, but it's spreading rapidly, and that's called Healthier Together. And that's what 0 to 18.nhs.uk. And there's some really good videos, both from parents and clinicians, that can talk you through if you have concerns about your child. And these are all really practical resources, and I can share them with the Marvellous Medicine team, and perhaps we can send those out to people who are on the call. So that was a rapid run through, and what I've covered is some of the challenges that we have in that diseases are relatively rare, some of the common conditions that we see, some of the things that you as parents and carers and the public can do to help avoid needing to come to the GP or the emergency department, and then some of the things that we can use to help pick up when a child is ill or not. I really hope that was helpful, and I'm happy and looking forward to some of the questions about what I've just talked about. Thank you very much for your time.